Good afternoon, everyone, and welcome to the Baldrige Foundation's Institute for Performance Excellence webinar, the Leadership Challenge. Should be the IT challenge today, but we'll call it the Leadership Challenge, managing and innovating through change. We believe you will enjoy today's webinar that will take a fresh look at leadership and management with insights from a Malcolm Baldrige National Award-winning organization and other industry leaders. Before we get started today, I would like to take a moment and recognize all of our great sponsors and a special thanks to the members of the Mac Baldrige Society who serve as the trustees for the Institute for Performance Excellence. And here's today's agenda. Our guests are Dr. Roger Spoolman, co-host of the Foundation's Leader Dialogue program, John Raffoul, President, Adventist Health White Memorial, Dr. Chuck Peck, co-host of the Baldrige Foundation's Leader Dialogue program, Dr. Darren Versillo, co-founder and chief medical officer of About Healthcare, and Ben Sawyer, vice president of transformation engineering, About Healthcare. Following their presentation, we're going to have questions from the audience and a few closing remarks. Now, Roger, I'll turn it over to you to get us started.
Great. Thank you, Al, and thank you all for your patience with us as we get organized here, but we're really looking forward to today's discussion as usual. We've been talking about what is the most helpful thing that we can do for you to help you get some insights in leading through change, and what role we can play through the Baldrige Foundation, taking advantage of all the resources of the foundation to bring you some help and hope during these difficult times. And we've got a great panel today, as usual. John Raffoul, if you've listened to his Leader Dialogue if you haven't listened to his Leader Dialogue interview podcast with Chuck, you ought to do that. Make sure that you do that, because John is a great leader. He's, as many of you know, he is the president and CEO of Adventist Health White Memorial, and he's the 2019 recipient of the Malcolm Baldrige National Quality Award. And he talks about their journey, and it truly is a journey. Been working on this for many, many years. And it's not just a program, as you know, it's really a commitment to a real lifestyle in terms of leadership. So, John, we're so happy to have you with us today. Thank you so much for carving out time to be on our panel. Dr. Darren Versillo may not be with us because he became not only he's a provider, but he became a recipient and a consumer of healthcare. Ben tells us that he had a little skiing accident, and so he tore his ACL and he's recovering from that. So we may not have Dr. Versillo with us today, but we'll do just fine without him. Here's what we're going to be talking about today. Here's the background. As the title says, Leadership Challenges of Managing Innovation and Innovation Through Change. We've been talking a lot about this amongst ourselves and with podcast guests. And we sort of said, we asked ourselves, what were we working on before the world turned upside down in 2019 and 2020? And are those topics relevant still today? So we would like to talk about some of these hot topics and then say, what would we do differently if we could change and utilize the information that we gained through living through this difficult period? And what would we do differently today if we knew that was going to happen? So we do this format of so that's the hot topics. And so what does that mean to us as leaders in healthcare? And then now what? Here's our section of hope for the future and how we can help ourselves move forward. So in the so what category, what can we do to make up for lost ground? And what questions should we ask ourselves and our teams? And what should be at the top of our agenda in our leadership groups? And we want to talk about innovation. And because through the pandemic, we've had some amazing innovation come through, some things that very few systems have been working on, like telemedicine, and it just accelerated so rapidly. because out of necessity, of course, we had to do that. And so that is the type of thing that has helped us. Now let's not go backwards. Let's continue to go forward with innovation, and let's use our Baldrige framework to talk about how that impacts our leaders, our leadership teams, how it impacts our medical staffs, how it impacts our consumers. So that's basically what our agenda is for today. And so let's get into some of these hot topics and see what was going on back in 2019 and what's happened to those issues. And the first one that comes up is consumerism. We are consumer facing. Healthcare talks about being consumer facing. We give a lot of lip service to being consumer facing, but let's be honest, we really are about managing our own resources. And we didn't really appear to be very consumer facing during the pandemic because we had so many priorities to manage. And so we became, I think we caused our consumers to be a little bit suspicious of our claim to be patient first. And we kept them out of our health system. And we tried to treat them or to accommodate them in ways that were possible and convenient for us and not necessarily for them. And so we've had to now try and claw our way back and see how we can accommodate our consumers and how we can reinforce to them that we really are focused on their needs and on their time. And Ben, I think you have some comments about this.
Yeah. So what's important to consider here for the audience is this: we're not talking about whether we care or don't care for the patients, because everyone does that. I think there's no question there. It's more the consumerism characteristics. Like, for example, under number 2 there, convenience, accessibility, and quality. Consumers have identified the number one roadblock is just getting connected to the office, and they look at stars on providers online, right, on social media.
Absolutely.
So for them, it's how quickly can I get in? Is the price right? Am I getting a good interaction with my provider, etc.? And as the number of different care settings and provider options have increased in the pandemic, that has made it even more challenging. Whereas pre-pandemic, there were less of those, which we'll get into. Now consumerism is having a much bigger impact. So it's not about whether we care or don't care for the patient, because we all care. It's just gaining access and being able to have consumer-like feel to it, which has always been a little tough for us in healthcare.
Yeah, and it's adjusting we've got all these complex things that we've had to deal with. And how do we get back to this and really focus on our consumer needs? So great. Any other comments on this particular topic?
Chuck, did you want to talk about the digital front door and the impact there?
Well, I just wanted to mention a couple of things in terms of access and convenience, et cetera. And whether we, as a former physician, patients vote with their feet. And, at the end of the day, the patient's going to make the decision on what they want to do. If there's the other thing to consider, though, is if you still believe that the primary care physician or provider is one of the main front doors for patient access, you have to be concerned about that as well if you're a hospital or a health system with a large number of physicians. And the reason I'm saying that is that the primary care market, just primary care in this country, is over a $250 billion market. And some are predicting that within the next 7 years, 30% of that market of primary care physicians will be affiliated with one of your competitors right now. And I'm not talking about a traditional competitor like a health system. I'm talking about the Amazons, the Walmarts, the CVSs, the Walgreens. And that's a serious consideration as well. So in thinking about this, I think you also have to think about what strategies you're going to utilize in order to find your way through this non-traditional healthcare market, which I think you've probably already seen some of that market share being taken away. And I think that's also a consideration. So this digital front door issue that Ben just brought up is really, really critical. COVID really forced us all to figure out how to do telehealth really, really quickly. And, I think that we managed to do that, but there's a lot of entrenched interests out there, whether it be the government, payers, insurers, whatever, that are looking to retrench and pull away reimbursements and other things that you're all aware of. And so how do we continue to advocate for our patients and make it more convenient for them to come to us, those that are still coming to us, meaning the people in the audience, so that they don't get attracted to places where it's easier for them to access?
And Chuck, thank you for that. We were talking about this recently offline about the level of satisfaction. So the bar has been raised, hasn't it, in terms of patient expectations and in access, timeliness, value, that sort of thing. And so not only are these not what we call non-traditional providers vying for the same patient population that our health system friends are, but they don't have all the complications, all the complex care complications that we have. And so they're able to focus on that patient experience, and they're doing a really good job, aren't they?
Yes, they are.
Yeah.
Roger, if I might add as well, it's all about convenience. I think Chuck mentioned that. So patients don't want to wait 4-5 weeks to be able to see a doctor anymore.
Right.
Patients are carrying their mobile phones with them and shopping around. What doctor can I see right now? And the first doctor that answers them say, come on over, they'll go there. So it's about convenience. How can you make access to healthcare convenient to the patient? That's where you have the rise of these mobile apps and, physicians at home, physicians going and making visitations at home, because consumers really want availability, they want access, and they're no longer willing to wait weeks to get that access. So I think we have a big challenge in front of us to accommodate the patients, because consumerism is real in healthcare right now.
It sure is. Thank you, John, for that. That's so true. And instead of having, my doctor waiting to see my doctor, I'll sacrifice for convenience. I'll see any doctor that can help me with that. So yeah, we got some challenges in this here. So John, this next slide is something that I would love to have you weigh in on, because I know you're so focused on, community-based organization, becoming a community-based organization and addressing social determinants of health. You've done such a fabulous job with your system. I loved researching it and reading about it, but encourage us. Will you tell us how you've done it and why this is so important?
Well, thank you, Roger. Yes, because, it's easy to just say, people have poor health because they don't have access to hospitals. They don't have access to good doctors. They don't have access to technology. But the truth of the matter is, when you're hungry, the last thing you worry about is whether you're going to see a doctor or not. The first thing you worry about, where am I going to get my next meal? If you're homeless, your worry is, am I going to have a shelter? I'm going to freeze to death tonight, or do I have a shelter where I can go feel warm? Healthcare is the last thing on your mind. So there's a lot of things that the social determinants are critical to address if you really want to have a healthy population. You have to address their food insecurities. You have to address their housing needs. You have to address their behavioral health challenges. You have to address their economic, well-being. So a lot of things that really lead that you have to address before you can say, what, am I delivering the right healthcare to these patients or these people? Well, for us at Adventist Health, White Memorial, we recognize that healthcare starts with making your community better, making your community healthier before you start advertising. Come for, we have a 24/7 ED. We have a heart program. Well, so what we launched is what we call the Blue Zones. The Blue Zones is a program that identified and looked at the 6 areas in the world where people live the longest. We tried to learn from these 6 area, Loma Linda, by the way, United States is one of these blue zones.
Right.
Sardinia is one of the blue zones in the world. So there's 6 of them. And what people found out is your health is determined by how you live your day-to-day, routines. What do you eat? How do you exercise? What kind of, do you belong to a church? Do you belong to a social group? So we tried to learn, from these 6 zones, what really makes a population, healthy. And we launched that for both our campus, for our employees, and we also launched it for our community. And this will allow us not just to do these things, but also to be able to measure whether we're making a difference or not. White Memorial, over the years, we have qualified as the second in the nation when it comes to doing work in the community. But I'll be honest with you, we did a lot of things, but we could really not measure it and say, you know what, because of the work we have done, we have so many less deaths from heart disease in East Los Angeles. We have so many people, controlling their diabetes and not dying from diabetes because of what we did. We couldn't get to that finite way of measuring, are we successful or not? So the blue zones brings us the ability to say, this is what we did. These are the results that we have attained in our community directly. So, which is a nice thing that we're able to measure whether we're being effective or not. And we address everything. We address financials, we address housing, we address chronic disease, we address food insecurities. So all of these things are all being addressed as part of our effort to make our community a healthy community.
And John, thank you so much. John, you've been on this journey. Now, you've been at White Memorial since, 1992, I think, and
well, I've been here 35 years.
Yeah, that's amazing. And I think that's part of the secret to your success, or the organization's success, the consistency of your leadership. And you've been the CEO since 2015. But during COVID, what changed? I don't think your commitment to the blue zone changed, but maybe the methods changed a little bit, but you just kept on going, didn't you?
Well, we did. During COVID, we distributed over 150,000 meals directly to our community here. So that was part of the things that we kept doing, so we did not ignore the needs for our community. But it was tough. I mean, during COVID, it was not an easy journey because you want to keep taking care of your community. You want to keep giving food security, taking care of what they need. But at the same time, you have people dying daily at your hospital. Yeah. You had people in the ED trying to get in. You got overwhelmed. We're trying to learn what works, what doesn't work from a medical perspective, how to treat those patients. So it was tough. However, during that period, I think it works both ways. We did a lot of things to help our community with vaccinations. We've given more than 60,000 vaccines, here at the hospital. And honestly, we were the first one to vaccinate across the entire city. We went all the way to the western side of the city, and people were coming. The teachers were coming from West LA to East Los Angeles to get vaccinated, to do that. So we did attend to our community during that period of time. We didn't forget our community. But I'll be honest with you, it's a two-way street. Our community also took care of us because we had tired physicians, we had tired nurses, and we had them come with their classic cars, go, parade through our campus and honk their horns and thank our heroes here at the hospital. We had the police and the fire do flyovers over our hospital. We had the National Guard that that came and helped too. So it's never a one-way street. Where you really take care of your community will take care of you as well. We had places, that we never even knew they existed, bring food to the hospital and bring food to our staff to feed them during that time. So it's a two-way street.
That's great. Yeah, Chuck.
So, hey, John, it's great to see you again. I want to, as a former hospital CEO who had a 70% excuse me, a 70% Medicaid and Medicare population. And I know you serve a very similar population.
Mhm.
The elephant in the room is that, the payers haven't necessarily come along the way you've just been describing what you've been doing. And I'm wondering how you've balanced, the payer situation, the reimbursement situation, and all the things that you just described that you've been able to do. How have you made that work? Because I assume there's a lot of people in the audience who are in fee-for-service environments. They know that they don't get paid unless they have somebody in a bed or are getting something done to them, a procedure, et cetera, et cetera. How have you reconciled, the payer environment and the reimbursement environment with everything that you've been doing?
Sure. Well, thank you for this question. I want to divide that question into two segments here, because there's a segment that I feel very strongly about. The first segment is when you're in a crisis situation, and COVID was a crisis. And when the nation and the population is going through a crisis like they've never seen before, I think it's inhumane to talk about money. I think in New York City, you had nurses and doctors come out of retirement to help because people were dying from COVID. When you have a tragedy facing the nation, facing your community, facing your people, you don't talk money. What you do is you roll your sleeves and you help. And that's what we did during COVID. We rolled our sleeves and we helped. And, and I mentioned in our previous podcast that we basically relied on our mission of living God's love by inspiring health, wholeness, and hope. And we felt on our mission to guide us through that period, because our mission is to really live God's love. And that's what we did. And we didn't worry about where the money's coming from, what's happening next. We worried about saving lives and being a good citizen. That's what we worried about. Now, having said so, always reality will hit you. Reality will hit you a year later when you're past that crisis mode. Now you're staring at losses in your face and you have to do something about it. Okay. So we did what, leadership calls for. We asked for help from the government. Our politicians were very supportive of helping us. We're able to get funding for some of the spending that we have done during COVID. It wasn't big enough to cover all our costs, of course. We're lucky if it covered 1/3 of the money that we spent. However, it was something. So we're able to reach out to the government. I mentioned earlier how the federal, the Air Force came to help us. The Army Corps of Engineers came to help us. The state sent us nurses. They built us a field hospital during COVID as well. So the government, our politicians, were extremely helpful in giving us the help that we need. Now, the rest of it honestly fell on our shoulders. I had a company by the name of Huron that came in and helped us, I should say, to go through this year and make sure we have a turnaround plan. We had a $20 million turnaround plan that we initiated through Huron that went through it. Now, very tandem with that, we had our own turnaround plan for $30 million. So in total now, I'm talking $50 million worth of turnaround plan. And thank God we ended up the year, which is supposed to be a disaster, we ended up close to break even.
Wow, that's great.
Wonderful.
So
That's
yeah,
great.
and this year, if we had not done anything, we probably would be staring at least $30 to $40 million in losses. We ended up close to break even. So yes, you still have to practice, good management, good leadership skills, and you have to address these things and find efficiencies in your work, in addition to working with funding sources to get as much funding from government and charities that you can get. I mean, we had people donate over $1 million. We had Oscar De La Hoya, the boxer, if you heard of him, donate over $1 million to help the hospital during this crisis. So we had multiple avenues to make sure we stay afloat.
John, you are, and then you talk about this in the podcast interview, which is great. I love talking about the fact that you're a faith-based hospital. You're part of the Adventist system. So you had a lot of support to do this sort of ideologically with your board, with your system, with your employees, your medical staff, all of that. And that's a very unique thing. It's not just owned by faith-based hospitals, because there are a lot of non-faith-based hospitals, government secular hospitals, who did kind of the same thing, but it's just part of your nature. It's part of your mission. When we think about other emerging players, and we see, Apple, Walgreens, Google, CVS, Walmart, these guys are not faith-based. And they also don't have all of the extra requirements on them. They can carve out small pieces of the healthcare system where they can make money, or where they can serve customers. But their overall goal is not to, share God's love, as you suggested, your mission talks about. So when we think about the payvider, this is an interesting word, and we want to make sure we don't want to offend anybody by being too simplistic, but we also don't want to assume everyone knows what we're talking about. And these are some things that we're seeing happen in the payer world and the provider world. And there's a blurring of the line between the two, or there's a best of both worlds. And Ben, I think that you have some thoughts about this as well that you might like to share with our audience.
Well, yeah, I think just for clarification, by the way, I love biasing the conversation towards what John is saying, because it's so important and relevant. I would just say opportunistically during COVID, there were a lot of non-traditional players that came into the market. And these are players that specialize in direct-to-consumer services. They're very good at it. And so they were able to come in a powerful way. And as the care environments transitioned away from acute care to a lot of different alternatives, telemedicine, hospital at home, et cetera, these non-traditional players were able to come in and really establish a beachhead. And there also, to your point, Roger, was this evolution of the payvider, which is organizations that are both. They're health systems that are now payers, and they're payers that are now providers. And that also has its own velocity and momentum, which just creates a different challenge now in this new era for health systems to navigate through.
Great. Thanks, Ben. Let's go to the next slide and talk about command centers for just a minute. And all of us have become very familiar with this rallying the troops, getting everybody that has insight and has management control or influence around certain topics. And so this has become a new way of life for all of us in healthcare, these command center type operations. And there are different functions, core functions, the incident response center. This is not terribly new, but it is of the last maybe dozen years or 10 years, talking about ways to immediately respond to some need that goes on, an emergency, severe weather, that sort of thing. And so we're familiar with that. Security and operations centers are another type of command center. Integrating services, looking for how we manage our systems that give us updates and alarms and early warning systems and that sort of thing. So that's another type. And then facility and buildings operations. There's so many things that could go wrong, and how do we use a command center approach to ensure that our facilities and our operations are working to help us. And then finally, the capacity management center. And again, I'm going to turn to you, Ben, and talk about how we manage our resources and to make ourselves more profitable, and at the same time, don't waste time with our providers, our resources, our human resources as they.
Yeah. So this slide was just trying to kind of represent what was happening up till 2019. There was a lot of this going on. Obviously now, with the transitions of care being much more rapid and much more diverse, the command center concept has had to evolve, which I think we're going to get into later. So it started from this sort of 4-point structure typically, and now is evolving into something much more sophisticated with artificial intelligence and machine learning and load balancing algorithms and things like that, which we'll talk about here in a little bit.
Great. Thank you, Ben. So we are to the point here where we've said these were some hot topics. These were some things that we had to deal with back before COVID hit us in the face. Now, what would we do if we had this do-over button? Would we do things differently? Would we have spent time focusing on certain things? And the one thing that we've come up with or ask ourselves, would we have prioritized innovation more? And so we have some, McKinsey's done some work in terms of looking historically about investment in innovation and kind of market capitalization and innovation. And so taking it out of sort of crisis management to the daily operation. And there are some innovators that have really stuck with it and made a significant investment in using all of our resources and treating our patients more effectively. And it's not just something that you just pull out of the hat. It's something you have to be committed to and invest in, to make sure that we don't have to play catch up, make sure that we stay ahead of some of these non-traditional providers. So we're looking at what's going on in the environment, in the marketplace, and then using our expertise and resources to stay innovative and new in terms of, and current in terms of how we care for our patients. So any other thoughts on this slide before we move on?
Well, the interesting thing about this is the proof of the pie is in the pudding, right? I mean, often when you're in a crisis, innovation is the last thing you want to do. Seemingly, you want to hunker down and protect your assets and resources. But what the research is showing is that actually that's the best time in some ways to innovate. And there is a better return of those that did that versus those that hunkered down. The question here, I think, and this is coming from our friends at the Health Management Academy, is then what do you invest in? How do you balance your cost containment with investments, right, to diversify your revenue? And what areas would leading health systems take a look at? And Fitch warns that particularly the nonprofit sector will likely require some pretty transformational changes to offset the short and longer term pressures. And for example, being able to become much more efficient and effective in managing the transitions of care within this rapidly expanding care environment. So it kind of comes down to, we'll get to it later. It comes down to the position that organizations will take as to whether they hold the line and retrench, or whether they innovate, or a combination of both, depending on their particular circumstances.
And really, we've talked about this offline. During 2019, 2020, there are very few industries and organizations and fields that weren't touched by this and didn't have the opportunity to innovate. Every restaurant now became very focused on takeout. Yep. Even if it wasn't, even fine dining restaurants, had to really focus on takeout, and that hasn't really slowed down. Every restaurant still continues to do that. Transportation companies, hotels, everyone had to innovate. Yeah, grocery stores, everything.
And John, were there certain areas of your operation where you had to just look at it differently coming out of the pandemic than coming into it from an innovation standpoint? You're on mute.
John?
I'm sorry, I was on mute. Can you hear me now?
Yeah, we can hear
thank you. Telemedicine is one example of, I remember when we first went into the pandemic, finding a good telemedicine platform was not easy. You had to really shop for it, look for it, and you're lucky if you found something that works. I think after the pandemic is over, people are still using telemedicine very successfully to this date now. So that's a transformation I think we made in medicine in that respect. Hospital at home is another innovation that happened during the pandemic that many places continue to use it. Now, we did use it during the pandemics. However, we didn't have a use for it now here in East Los Angeles. However, elsewhere in our system, in the Adventist system, they're still using this model as well. So hospital at home is an example of where you have constrained capacity. Now you could continue to use that well. So there's several things that we kept using and doing past the pandemic that we didn't, that help us, and would continue to help us going forward. Now, during the pandemic, also, you said during crises is the last place you focus on is innovation. Well, I could tell you that during the pandemic is the time when we were reached out to hospitals in China and South Korea and said, teach us, guys, you went through SARS 15 years earlier. Help us. How did you deal with that?
Right.
And we learned a lot from it. As a matter of fact, one meeting that we had with them, they talked about how they had separated the cafeteria chairs and tables and put plexiglass in between the chairs. And honestly, we had not done that here.
Mhm.
And we came back and looked at our cafeteria and said, wait, we need to do that. So things like that, even during crises, you can look outside your box and see what other people have done before you that went through an experiment like this and learn from them and implement things we've never done before.
Yeah, that's
So
a
it
great
works
example.
both during crisis and post-crisis as well.
Yeah. And Roger, another example, we talked about the command centers earlier. I've worked with command centers most of my career, as you know,
Right.
and they had largely been acute care centric, right? You're looking at bed management, you're looking at patient itineraries, the use of diagnostics and so on. With this changing environment, there's even more of a need now to sort of have a command center with a front end focus, kind of an access focus, where it's like, hey, what assets do I have to help meet that patient need? Might they be better served in a service line versus just bedding them? And what exactly, from a load balancing standpoint, do I have? And this is where some of those artificial intelligence around load balancing algorithms to say, based on these characteristics, this is the best place to put the patient, can come in. It starts with the very fundamentals, like, you have people, process, and technology, right? And you have very key performance indicators over here on the right-hand side that you want to make sure that you're leveraging and focused on. And then it's a matter of kind of organizing the different assets or resources that are a part of that to sort of optimize your care orchestration so that you can more effectively function as an entire system in terms of the access, the progression, and the transitions of care, whether it's acute, post-acute, social determinants, community-based resources, et cetera. So we are definitely seeing the maturation of command centers to accommodate that much broader footprint.
There's something that's even more basic, even though everything you said is true and helpful, but something that is even more basic with this command center approach or the daily huddles, the daily command center meetings that many organizations had throughout all of this. When you have people, and there's so much going on, and it's really hard to know exactly what the truth is, what the reliable information is. There's so much rumor. There were so many unknowns in this period of time. And what happens in a time of uncertainty is people, A, begin to make things up, B, they decompensate, and the dissatisfaction goes up, and so all kinds of things happen that are not really helpful. And so by meeting every day in a huddle or having a command center approach where all the reliable information is resident within a few people and everyone can access it, you can go and find out what's going on and what the needs are and what we're going to. I think that just encouraged people to operate at the highest level of their licensure and their ability by just having the much better communication. So that's one thing that really this has taught us, how important that level of communication and trust is.
Yeah, Chuck, you were going to just comment on it, I think.
No, I was just going to say, I think when some people, when they hear the word command center, think about these multi-million dollar, 500 flat screens, et cetera, et cetera. I think that what Roger just said is really important. Even something as simple as starting by putting these people that are on this slide into the same room during each shift and having a communication, a fairly simple-minded communication structure set up so that everybody knows where the patients are at each point in their day. Even having an ancillary coordinator here to make sure that when you have certain patients ready for discharge, that they're put up at the top of the list on discharge day to have whatever they need done first. That's not rocket science. That's just fairly inexpensive, simple coordination and communication. And, we did this very successfully at the health system where I was, because, we were forced into it by our financial situation, by, our overwhelming number of inpatients, and our payer balance, et cetera. And it's amazing how something as simple as what I just described can cut almost a day of length of stay off, and at the same time increase the physician, nursing, and patient satisfaction at the same time.
Right. And when you
Thanks.
add in, again, predictive data, real-time data, predictive data with supportive algorithms and machine learning, it can really help those teams to function much more effectively. And to your point, it doesn't have to be co-located then. They're really connected digitally, right? And through their teaming efforts to be able to be quite successful. Yeah, those are really great points, you guys.
Yeah. Okay. I'm going to take a look at the clock here, and we're going to fly through some of these things, but I just don't want to pass by without saying the performance guidance from Baldrige is there to help us get the results that we need. John, you have lived this, you're 22 years, your organization has been on this Baldrige journey. And again, it's a lifestyle. It's not a diet, it's a lifestyle, right? And it's not just a special program. And so, again, I want to refer people to the podcast and to all the resources available through Baldrige that are designed to help us do this, to focus on visionary leadership, to focus on managing for innovation, delivering value and results. And so thank you, Al and team, for all that Baldrige makes available to us to help us. So now we're at the point where, so what? Okay, what can we do today to make up for lost ground? We've read in the news that Walgreens, for example, is now doubling down on physician acquisition. Chuck just talked about that a little bit ago, about how this is still the model. If we can control the kind of physician interaction with patients, they're the portal to our health system, the pathway to our health system. And so Walgreens is saying, hey, we're behind CVS and Optum and others. So they're doubling down on physician acquisition. So more competition for us. So what are the questions that we should be asking ourselves and our teams? And what should be on our agenda as we go forward in dealing with all these things? So, we obviously feel that prioritizing innovation is one way to really help our organizations not only survive, but thrive. And these are the questions that we suggest that you be asking in your senior teams and in your department level organizations. And what can we do to innovate? What must we do to innovate and become more effective at utilizing our resources and managing the needs that come to us through our patients? So the right side is, wait until there's more clarity. Well, you know what? It's probably not going to come. And so we're saying, let's go and take some risk and really begin to be known for innovation. It's more than process improvement. Process improvement is critically important. We can't step away from that. But innovation is more than just process improvement. It's taking some risks. So again, more Baldrige guidance. What are the ingredients that we need to provide meaningful change in our organizations and create new value for our stakeholders? We should go ahead, Ben. Sorry.
Well, I was just going to say, to your point, innovation and continuous improvement, They're different, but they're very complementary.
Yes,
As
they are.
Baldrige points out in this last, and successful organizations are obviously using both approaches to really improve performance. And typically the route they're taking is this, where they start with their inputs of people, technology, process, but they look at what are the metrics that are really going to matter, and they work backwards. And they say, under what circumstances could we change those things to get a different outcome? And then you do rapid cycle improvements, and you could fail fast. So you deploy, and what works, you stabilize, and then you optimize it. And it's this continuous improvement cycle that is, John, to your coaching, is always a part of what Baldrige teaches, right? Is how do you learn and adjust rapidly based on what you're finding in your operation to be able to continuously improve. Your thoughts on this?
Yeah, I think honestly, when it comes, why is Walgreens now jumping in, and what's in it for them, and why are people interested in going to Walgreens instead of going to your local physician or going to your hospital to get the care, or the local group? Well, it's very simple. They go to Walgreens, they are seen right away. They know exactly what they're going to pay. They know how much a physician visit's going to be. They know how much it's going to cost them, and they can get the access to results immediately. A lot of times in hospitals, they don't know what the price is. They're told one thing and they are billed a different thing. They're billed by the hospital. They're billed by the doctor. They're billed by the anesthesia group. They're billed by the lab. They're billed by the radiology. There's no transparency, and there's no pricing you could give them ahead of time. Try to schedule an appointment. You wait a long time to get to the appointment. And then last but not least, try to get your results. They're not that readily accessible. So what we are learning from this process is our price needs to be transparent, needs to be given to the patient upfront. We did partner with a company that helped us achieve that, pricing transparency, and be able to tell the patient, this one, what this visit is going to cost you today, and if there's complications, this is what we do to address that. So they know upfront what they're going to pay. You have to be able to give them access. They need to be able to schedule an appointment electronically, via phone, via computer, whatever is faster for them, what they like to use. So access is important. And last but not least is when they're all done and did their tests or what have you, they need to be able to have a portal to be able to sign in and figure out what's wrong with them, see their lab tests, be able to sign on that portal and see what cholesterol level is, what's their AC level, their blood sugar level is. So these are things that hospitals are way behind in, that we could learn what Walgreens does, what CVS does, and try to get into that space before they eat our lunch, frankly.
John, all those things that you mentioned, I was thinking about this. Today's Wall Street Journal, I don't know if anyone has seen this, there's a special section in today's Wall Street Journal on wealth management, but the title is How to Negotiate with Creditors to Reduce Your Debt. And whether it's the IRS, hospitals, credit card companies, et cetera. So, we're in the crosshairs again, with organizations like the Wall Street Journal telling our patients how to negotiate the debt that they have, or the payment that they owe us. And so, just more complication.
Chuck, you're on mute. You're on mute, Chuck.
Chuck, we can't hear you, buddy.
When we talk about innovation, I like John's comment on this too. I think we need to make sure we talk about innovation and leadership as well. And, we've talked about some of this on my podcast, and I've been a strong proponent of this because I've seen how important it is. But, the latest statistics show that of all hospital boards, not-for-profit hospital boards in this country, 17% have physician members. And a lot of what we just talked about, in terms of the some of the ideas that John was talking about, what's needed, physicians have been talking about this for years and years and years and years. And I just wonder whether or not it's also time for us to start thinking about how we innovate and bring our future leaders on board. and how we make sure that a number of those leaders are clinical leaders who are on the front lines every day and really truly are the ones that understand what a lot of these issues are.
Great point, Chuck. With just under 90% of all of our physicians, primary care physicians employed by the health systems, and maybe around 60% of specialty physicians now, which is crazy, but that's where we're at. We have to listen to them. Absolutely. We have to listen to them and get their help in terms of how to manage this. Well, just in the remaining minutes that we have, so now what? So what do we do to go forward? And I love this graphic talking about how we become strategic thinkers here and what are the resources that we need to think outside the box, to be a systems thinker, what's the cause and effect and that sort of thing. So what are all of the components needed to help us do that? Who are the role models and how do we create systems that are truly healthy operating systems? And, this cascading scorecard, we measure what matters, right? We're looking at these things that really will get us the fruit. It'll produce the fruit in the organization. And it doesn't happen overnight. It takes time and it takes commitment to this structure and this system and doing things right. Individuals, teams, departments, business units, divisions, corporate, all of it, this vertical alignment has to be there in order for us to get the fruit that we're looking for. So do we have some questions? Do we have some questions from the audience? We're really open to addressing anything that you have for any of us, John, or any of us as panelists.
We do have a few questions, Roger.
Okay, great. Thanks, Al.
And the first one is, how should we think about innovation in the context of all the financial challenges we are currently facing?
Okay, great question. And that's the reality of it. There are lots of things that we could do. It'd be nice to do, but we do have this financial crisis facing us. And I think Ben wants to take a stab at this.
Well, just as a first comment, I think the initial reaction, which is we don't have the funds to invest for innovation because we're just trying to protect our base, is counterintuitive. And innovation doesn't have to be expensive. It's just thinking about things differently. It's taking, like what John just talked about, what do patients actually need? Why are they going to a competitor like that? If we just take that thinking and bring it back to our organization and say, what if we did it that way? How could we change? That doesn't have to be a costly effort. It's just in thinking differently and investing differently. John, I don't know your thoughts on that. You're on mute.
Yes, I agree with you completely, Ben. I think those who are going to survive in the long run are those who are not going to think about our service as a service to the insurance companies and to the payers, but really a service to the patient. Mm-hmm. And that's a different frame of mind to have, is my client is the patient, not the PPO, HMO, and the insurance company, because the new generation doesn't think that way. Now, right. We keep saying the baby boomers. Well, the baby boomers now are getting older. We have a new generation coming in. The new generation doesn't put up with that kind of mentality. The new generation wants service. The new generation wants to see a doctor. They want access. They want information. And those that cater to the new generation are the ones that really are going to survive in the long run. And to be able to do that, you have no choice. You innovate or you die.
Yeah.
There's no choice.
Well put. Well put. Thanks. Al, do we have another question?
We've got a few. The next one is, how has the scope of the command center changed post-pandemic?
Just quickly on that, and you guys jump in, what I was alluding to earlier is it's really expanded. I mean, it went from a primarily acute setting, right, where there was a lot of complex care going on, to a much more diverse transitions of care setting where you're really dealing with the community, the social determinants of health, post-acute care networks that are curated to make sure that you can get patients rapidly to the next level of care and or home, hospital at home, et cetera. So that is stretching the boundaries of command center functions in this new environment, and people just have to be aware of that and respond accordingly.
You know, that's another topic that we've talked about offline recently, is this sort of an epidemic of dissatisfaction that we're seeing in all sectors of healthcare, you know, in senior leadership and the medical staff and the patients and staff, you know, nursing, everywhere. People are dissatisfied and frustrated. And I think we've talked about this before, the command center approach or the team-based care. Team-based care is what really made healthcare great in this country. And we've sort of lost, or we've got to get back to team-based care and get people engaged in the process. And this, not only command centers, but we need to push it all throughout the organization, have sort of a command center-like attitude throughout. Ben?
No, I was just pointing to someone was going to come in and talk to me, and I didn't want to
Oh,
interrupt
sorry.
right now.
Sorry, I thought
Yeah.
you wanted to say something. But
Yeah, no.
Yeah. Okay. Time for one more, Al.
Sure. If I decide to partner with a payer, what criteria should I use to determine the best partner fit?
Ooh, Chuck, do you have some thoughts on that one? Take yourself off mute.
That's
though.
a really important question. You know, I think that the cultural fit and the vision and the mission is really, really important to really delve into. You know, I know that the payment is and reimbursement is really, really on top of mind for everybody. But, you know, I think that you know, looking at the big issues that we have currently and making sure that those are going to get better. What's a huge issue that I assume you have? Denials. Let's start right. How are you going to control, as opposed to them control, the care management process? How are you going to control versus them control who gets care, where the care is delivered, who delivers it, et cetera? You're obviously going to have to prove that you're providing valuable care, meaning high quality, low cost care. But you want to make sure that the payer looks at those things that are really important to you in the same way as you look at them. And also, very importantly, how many patients, how many folks in the community are they able to bring to your organization? It doesn't do much good to you know, partner with somebody if they don't have a lot of patients to bring to your physicians, your nurses, your hospital, et cetera. Those are some key things I'd be looking at right off the bat.
Great. Thank you, Chuck. And I think that's about it for our time. I just want to encourage our audience to hang in there. Don't give up. There are great resources available to you through Baldrige, and we want to do whatever we can to help you in this journey and to help you to continue to fulfill your mission, to meet the needs of your communities and your patients. So thanks for being with us, and thanks for your input. And back to you, Al.
Thanks, Roger. John, Ben, Chuck, and Roger, thanks again for such an engaging and informative discussion today. As a reminder to everyone, the Foundation's Institute for Performance Excellence has more than 400 training and professional development certification opportunities offered online and at your own pace. This month, we are showcasing two of our most popular online courses, Supply Chain Management and Lean Healthcare Professional. You can visit the Institute website at baldrigeinstitute.org/education to learn more and to register. Thanks again to everyone for attending today. As a reminder, a recorded version of today's presentation and the slides will be available on the Foundation's website early next week. And once again, thanks to all of our sponsors, especially members of the Mac Baldrige Society, who are the trustees of the Institute for Performance Excellence. It is their generous support that make today's presentation and others available. Thanks again for attending, everyone. Please be safe and have a great day.